So here is a 59-year-old gentleman presented with non-ST segment elevation myocardial infarction, which showed basically a double vessel disease of left anterior descending artery and left circumflex artery. The comorbid condition here is a type 2 diabetes mellitus. LV function was normal and renal function is also normal. Syntax score comes 20.5. There is LCX after the OM has got a significant disease. In the next image, we can clearly see the ostial OM has got a tight lesion, 90% stenosis. And the middle one vessel is a ramus intermedius and LAD is missing. Basically, it's a total flush occlusion from the ostium of the LAD. And in elevocranial also the same finding we can see, but we couldn't see any antegrade filling of the totally occluded LAD vessels through any of the left side collaterals. So we can expect LAD can fill from the right side collaterals because the LV function was normal. So if we see the right side angiogram, good septal collaterals coming both from the PLV and the PDA, which is filling from the septal down the entire LAD. So if we see the totally occluded LAD segment, it is more than 20 millimeter in length and it is an ambiguous stump. So I think JTO score is 2, which has got an intermediate to difficult category.
Okay, so we have a bilateral puncture, right and left femoral, and we have a right French 7 French guiding catheter, and you can see that's EBU 3.5 into the left main. There's an RCA diagnostic catheter in the right, and we're going to do a simultaneous shot. And you can see in the simultaneous shot that we have the right filling the left very faintly. We also see antegrade, a very small trickle of the LAD, like a small, micro channel there into the. It doesn't seem, the history doesn't seem to be too long, so I wouldn't call this a chronic total occlusion. It seems to be 100% occlusion of acute form. So what our plan was to try to cross that LAD through antegrade and if possible wire down the LAD and then see what we see on the IVUS, if the disease is in the LAD or the circ. So we'll have to decide after as how we fix that. There are two options. There's not a big OM. One is we could just balloon it and get out and then fix the left main to LAD stent. And you can see it was we have a wire down the circ into the OM, and it was a bit difficult. We first used a soft wire, a cyan blue, and that was not going into the channel and was getting deflected. So in this scenario, what we do simply is to take a CrossFit 100 very quickly, and you can see now the CrossFit 100 is in the microchannel now, and with a little bit of push and twiggle of the CrossFit 200 wire, we could slowly go antegrade into that LAD. And then we take a retrograde right shot to see that we are in the main lumen. And you can see now that we got, after the injection of the nitroglycerin, that's a reasonable at least 2.5 balloon. So we have just dilated with the 2.5. What we have achieved till now is that we have crossed the near total occlusion with CrossFit wire 200. And now I'm trying to get the soft wire down that LAD. So we got a soft wire down. This is cyan blue. Now I'm now going to protect the circ with another BMW or something, a soft wire. Can I put the IVUS on the wire now?
So we can see the distal vessels are like a chronically hypoperfused vessels. So it is hugging the catheter wall. So which we generally expect in CTO after opening with the smaller balloon. The catheter size is 1 millimeter. So the vessels are going to be 1.2 millimeter in the distal most area where we have started, and as we are coming proximally we can see the vessel size is increasing. Though the lumen size is less, the vessel size is almost like 2.25. Now it's 2.5, and even some areas it shows even up to 3. We can see one branch is joining. Now circ is joined, the previous one is the diagonal, and this is the
left main,
and that's the aorta. From the left main, I think left main, there is some eccentric block is there, and there is a doubtful there is a dissection is also there in the left main at 3 o'clock position. So I think better to cover up to the left main ostium, because just it is into the left main. and there is a block is also there in the left main. If you see the block burden here, it is 48%, somewhere near it's 50% block is coming, hence better to cover the entire left main. And as we are going, this is the ostial LAD. We can see the ostium of LCX is totally free of disease, and ostial LAD is reasonably okay, but there is a block is there eccentrically as usual in ostial LAD. And that's a diagonal. Again, we can see even into the not diagonal, that ramus, I think the next vessel is ramus. Even into the ramus ostium, there is a significant disease, and the size of the proximal LAD is looks like soft block, no calcium. So I think further dilatations are not required. Straight away we can go for stenting. So maybe we will divide the stent into two stents. First stent we will 23, 24, 24, something like that we will cover. Then we will take pullback, take a IVUS pullback. Then we will take a second stent. But where we are going to land the distal edge of the stent,
Because there's a septal there that seems, at least on the angiography, as a reasonable area where the artery looks better. Okay, so what we'll do is possibly,
Septal, okay.
yeah, it's about that septal area where I think the vessel looks.
so we have started IVUS pullback beyond the septal.
Yeah. So what we've now, Nanda has told us is that there is a lesion which is diffuse in the LAD. It seems to be, the landing point seems to be a good point is around that first septal. And we have a length of about total
30 millimeter from the ostium.
We need to now fix the circ, because if the circ needs to be done, we need to do that first before we fix the left main to the LAD. So I'm going to leave that wire in the LAD and then wire into the circ, and then what we'll do is finish the OM
Distal
first,
stroke.
and we now do the REO. So now we have a small check, please, where we are. So the issue is, if we're going to do that, whether we're going to do a balloon or we are going to do a stent to that. Okay, so what I'm going to do is I'm going to use the same 2.5 balloon. So I wired into the OM, my wire is distally into the LAD, which I'll keep it there, and then we will decide after we fix the OM how we go after the. It's right at the ostium. I don't expect a great result with a balloon. We could use a cutting balloon, but I'm not, when you have these small vessels, it's extremely important that you don't lose LAD wire now and all this confusion. So it's extremely important that your fingers are holding the LAD. And now I'm going to rewire, small check. And then we'll fix, after we do the OM, as Dr. Nandakumar said, we'll use two stents. Do you think a 2.5 will be good, or a 2.25?
We will take 2.25 because distally diffuse disease.
Okay.
So 2.25, 22 onyx, I think, which we can push up to 3.25.
Okay.
Then the overlapping stent, maybe next we will take 26 or 28. It depends upon the IVUS pullback.
Okay, good. So we've got a small balloon to just pre-dilate it. So what is happening is that the balloon is hitting the top and pushing back at the left main circ junction, because there is no chance that this could entwine now. Okay, so let's go very low inflation pressure, please. Normal is at 10, is it? 12. So let's just go 5, 6, 7. It's a bit oversized. So there is a concertina effect. You can see that there on the wire. So we need to be careful that we don't mix up that. So I'm just going to get this out and let me see. So I need a shot again. We'll give some nitroglycerine, take a shot, and decide what stent we need for the OM first. Okay, so we'll use a 2.5. If you don't, is it 2.5? Have you opened that? Or
We'll take 2.25 we will take.
Yeah, okay. So you can see the concertina effect of the wire, and it's in a small branch. Don't like that. So the plan was to fix the OM first, because in case you cross over into the left main, and you can see that the left main is diseased even on the angiogram to the ostium, then we'll have difficulty doing all this at that point of time. So what we're going to do is now fix the OM and then come back and fix the LAD after that. So this is a 225 15 onyx stent. Okay, that looks good. I'm going to go up there. Go to nominal, please. Yeah. And you can see that the stent has come up. It was not a very hard lesion. And I think even the 225 is a bit overdone for this vessel, to be honest. So that looks good. I don't think we need any more work on that. It looks a bit bigger than the distal OM, as you can see. I'm not going to post dilate this anymore. We are at 12, so we got a good result. We'll now proceed to do the main lesion, which is the LAD. And just, okay, so you can see the LAD is also coming up nicely. The best way to check a concertina is to move the soft bit of the wire across the area where it's suspect, keep it still within the stent, and take a shot. Yeah. And you can see it's all straightened out and there is no problem there. So now we'll go to the other view, back to the LAO caudal, and I'm going to keep the wire in that ramus now so that we don't have a problem when we are stenting that.
The left main is 3.75. Hence, we need to take a stent, next stent, which goes up to 3.75.
Yeah, so I think we will measure it after this from the stem to the ostium of the left main, and I think we may use a 3.0, which will go up to 3.75. Okay, so what we're going to put is a 225 stent, which is 22, which will cover from a little, maybe about 10 millimeters away from the septal backwards, and then use a longer stent, which is possibly with an overlap, which may be about a 30, I think. May deflate, please. So we got that open nicely now. I'm going to come back with the balloon and go up there. High pressure, please. And so we've decided now that since the disease is extending into the ostium of the left main, that we're going to touch the left main here, okay? So you can see here that this is exactly with a few millimeter overlap. Maybe we don't need a 30. We may need a little less, maybe 26 or something.
20, 26 is coming because the guide was into the left main. I thought that another 4 millimeter.
Okay, I think that's good. I think angiographically it's in fact bigger than the distal vessel. So 2 to 5 was the right size.
Now the question is 26 or 30.
So we can, what we'll do is, I will use a 30 and keep it a bit overlapped in the LAD, because there is no reason for us to worry. There are no major branches there. So now we're going at a 3 or 30. We'll fix the overlap in the left main ostium.
Maybe retrospectively looking 26 could be enough, but I think it's okay. We can additional 2-3 millimeter overlap. Is not
So
going to do
this
anything.
looks a bit outside. So we're going to go in a bit. Small check, please.
Yeah, this.
And that looks nice. Take one cine and then deploy the stent.
And we will target the lower border of the left main rather
We're
than the upper.
targeting the lower border and going up, please. Yeah, go ahead. Yeah. We will now check how good that ramus vessel is after all this. So let's go to a view where I can see the ramus. And then we will do the left main pot and then decide what to do after an IVUS. Okay, so we have a problem in that ramus as we expected. So we will need to do that ramus.
We'll take a third wire it and remove.
Yeah, well, the circ looks okay. The original circ is okay. Let's take the small balloon, the 1 millimeter balloon.
The ramus is now jailed. The wire is jailed.
Yeah, so we'll have to rewire it now.
So we'll take a third wire, rewire, then we will pull out.
Sure. So we're going to keep this wire in just for the landmark. And Nanda was very, very correct that we would land up with this issue. Well, there's no way you can prevent this, but that's the way you do it, you know. Anyway, the LAD is good, the circumflex good, patient has no pain, he's okay. And this is the third wire going in. And keep the 1O balloon, 1O balloon please. So the idea is to do the pot, the patient is stable, we don't have to rush anything here. And we don't want to go underneath the strut for the wire here, that's very important.
Actually, there is a middle portion of the left main, even the size goes up to 4.2, 4.3.
Yeah.
But majority of the left main size 3.75. Hence, we will do 3.75. Then if at all, if there is any malopposition, finally we will take up.
What I'm doing here is just doing the left main. so that all the struts are well expanded here. Small check. Deflate. And as I deflate, I'm getting the stand guiding into the stand. So now that I'm sure that we don't have an issue. So the LED wire, yeah, well, let's hold that. And, okay. It's very important that you don't get intertwined in all this. So 3 wires in the system. Got this side now. So we've gone at 375 up to 18. So how much is that size, please? Okay, now I'm going to get the third wire into that jailed. Okay, let's now take one angiogram both in these two views by the time the next wire comes in. Well, it's there, but it's still blocked. We need to get through. Okay.
But left main stent looks well opposed.
Yeah. Okay, so the LED is pretty well done. It's all that we need is to open up that. The IVUS was a very good predictor on that, didn't he? Didn't you predict it?
There is a clear cut just at the ostium there was a block.
So again, you can see that it's an acute curve. There's a wire blocking that origin. We're having some difficulty crossing that. Should be all right. May need a little stronger wire. Is that crosset which we use okay on distal tip? Aziz, can you have a look at it?
I think we'll try for 5 minutes, sir.
Yeah.
It should go through.
There is no ST change and the flow is okay. But I'd like to open it if I can. Let me just try for a few minutes and see how we go.
Start a timer. We will see for 5 minutes. Put a timer here.
Okay. What I'm going to do is try to get the other wire. Right, so try to gently get the soft bit of the wire.
A small check during wire.
What I'm trying to do is get the soft bit there so that I have a port for entry now. So you can see that's a search, so you need to go down the LED, come back, and can you go to the RAO caudal for a minute?
RAO caudal or PA caudal is also where we can see better. Here I think it's the origin is coming from the other point.
Yeah. So it's a bit on the top here, the origin.
I think LAO caudal is the better view.
Yeah, so let's go back to the LAO caudal. I'm going to take a bit of a chance here, get that wire further back.
These guys coming and
See
asking,
what happens.
I can't get the machine. Ask them to repair the machine.
Sometimes the soft part
We can't get the machine.
gives access.
I have no problem giving machine.
It's going to try for 5 minutes. Like Nanda said, the flow is still there. I don't want to mess around.
The other options are taking a dual lumen microcatheter and try.
I don't think there's any ST change or any discomfort. I don't want to.
Or another option is keep a IVUS live and we can try to identify the ostium and we can wire.
And let me try for a minute here now.
Check.
Small check. You can see the flows are still there. It's not that it's closed off completely. The important thing is not to let it close, you know. What do you think?
Yeah, I think we will keep IVUS. We'll get a figure of 8 appearance. Here it is nicely seen in the pre-procedure, but now it may not be seen. Yeah. But I will try to find that just after the LCX. We'll keep live and I will try to wire it.
Okay, the LED looks okay. The septals are good. Even the the ramus is filling. It's not that it is not filling. It's still filling.
We'll try for at least 5 minutes with the live IVUS. And then
let's get the IVUS in, please. Yeah.
Distal edge looks okay. Nicely expanded. And as we are moving proximally, still there is a scope of expansion in the middle portion of the stent. I think we didn't do any post dilatation for this LED
so we
stent.
just did a 2 to 5. So we can get the 2-5 balloon, sister, please.
And the 3 mm stent areas are well expanded. Only that 2.25 mm that overlap area we need to do. Yeah, maybe this is the LCX ostium at 11 o'clock to 12 o'clock. And so this area we can see.
Yeah.
So this you can see.
It's about
This is
1 or
this,
2 o'clock,
this is,
something
yeah.
like that. Yeah.
This is the area. Actually, the studs are open.